Next presenter is Dr. Nitish Arora, and his topic is reconstruction of ocular surface in post-chemical injury and ophthalmic socket.
Please remove those standby CH and all. We can't read the material on the screen.
Screen के नीचे ना
स्क्रीन का नीचे में जो स्टैंड बाई वॉल्यूम सोर्स वो पूरा मटेरियल हाइड कर रहा है.
Old gentleman who came to my OPD for getting prosthetic eye change. History of acid attack in 2015, and he took treatment for same elsewhere, underwent multiple surgeries, and this was the condition when he presented to me. So in this case, you can see scarring of the upper lid, you can see ill-fitted stock eye, there is a purulent discharge. On seeing without the COP, patient had scarring and ptosis of the upper lid. There is lash ptosis with lid margin notching. There is lower lid ectropion grade 4. On seeing the inner surface, you can notice a scarring in the upper lid margin with symblepharon formation, centrally placed PMMA implant, scarring of the medial canthal structures with loss of puncta, and lower lid ectropion. So the diagnosis of right eye trauma with ACID, anophthalmic socket with centrally placed well-covered implant with lower lid ectropion with upper lid notch and multiple symblepharon was made. So what is contracted socket? A contracted socket is dreaded complication of enophthalmos, which leads to shortening of onysis, ultimately leading to an inability to retain a prosthesis. Appropriate clinical care is essential, and adequate prosthesis wear gives confidence and quality of life to an ophthalmic patient. So socket contraction may be due to poor previous surgical technique, early removal of the conformer positioned at the time of surgery, incorrect wearing of the prosthesis, recurrent socket inflammation, previous external beam radiotherapy, immunological diseases like SJS, and chemical or thermal trauma, which was in our case. So pathogenesis of socket contraction goes back to activity of myofibroblast. Tawfiq et al. Have explained that a single injection of MMC, triamcinolone or 5-fluorouracil or bevacizumab reduces the number of myofibroblasts, reducing the tendency of socket contraction. Gopal Krishna classification was a very unique grading system which was based on the phonesis, depending upon the upper, superior, inferior, loss of phonesis and involvement of all the four phonesis. But it was upgraded classification by Tawfiq et al., which was based on the contraction, how much contraction is there. So our case fits into grade 3, which is advanced scarring with impossibility to wear prosthesis. So according to the system of contracted socket, we should go for volume deficit first and then think about the contraction. But in our case, there was no volume deficit. There was mild contraction in the upper and lower socket. So socket molders or entropion or ectropion correction has to be done. The goal of the management is to reform the scarred fornix and excision of all the symblephra so that reepithelialization occurs and increase conjunctival surface so that the prosthesis can be easily fit. In grade 1 and 2, use of specially designed progressively large conformers and upper and lower eyelid ectropion and tropion correction should be done. And in grade 2 and 3 contraction, phonesis may be deepened by positioning of autologous spacers. MMG is useful for moist sockets, skin for dry sockets, and AMG has been suggested as an alternative in cases of mild grade of socket contracture. So our plan was to make lower fornix deeper. So lower lid FFS, that is fornix formation suture with ectropion correction was done in the first sitting, which was followed by surface reconstruction and symblepharon release in the second sitting. So after fornix formation suture, this was the condition of the patient. There was a good lower fornix which was formed, and patient was able to close the eye, and the conformer, you can see it is well fitted in the lower fornix. But the problem was still there. There was an upper symblepharon formation. So a patient was planned for a symblepharon release with the AMG graft, and this was the condition after that. And after sufficient space is formed, patient was planned for a COP. And you can see patient was in a very better condition, and he was not concerned about the lower lid entropion which was occurring now, But so this is the pre-op picture and the post-op picture. So my take-home message in this case would be the presentation of a contracted socket can be extremely variable, and management always tailored made according to the specific needs of the patient. And management of contracted socket is based on two important findings. First is severity and location of the symblepharon, and second is the amount of residual or vital volume. Thank you.
Thank you, Dr.
Which
Nitish.
type of suture do you use for fornix formation?
Fornix formation, I usually use silk.
Which one?
40 silk.
20 silk could be better.
20 silk can be, it is more thicker. I prefer using 40 silk.
Thank you, Dr. Nitish.